Welcome to this program about smoking cessation. Although we are going to talk about some brand name products as well as some generic products in this program, I do not have any conflicts of interest associated with the presentation of this material. We'll start our discussion of smoking cessation by looking at the prevalence of smoking in the United States. According to the Centers for Disease Control and Prevention, in 2010 there were 43.8 million American smokers, representing about 19% of the adult population. Although this is a pretty significant portion of the population, it's a number that has declined drastically over the last 40 to 50 years. From 1965 to 2009, the percentage of smoking adults in the United States declined by more than 50%. However, in recent years, the declines have been much less dramatic. This slide is a combination of data from both the American Lung Association and the CDC. The 2009 data is from the American Lung Association, while the 2010 data is from the CDC. And as you can see, the numbers of smoking adults are pretty consistent from 2009 to 2010, still around 19 to 20% of the population. You can also see that in 2009, over 19% of high school students reported that they smoked, and over 5% of middle school students had started to smoke. It's significant that the percentage of high school smokers is nearly identical to that of adult smokers because this is the age where most people who smoke start smoking, and we'll talk a little bit more about that later. You can also see that men are more likely to smoke than women, with almost 22% of men smoking to just over 17% of women. Smoking statistics are also reported by age as well as race or ethnicity. As you can see here, the percentage of smokers by age does not vary that much until we reach the 65 years and older group. So once people start smoking, they tend to keep smoking. And when reported by race or ethnicity, American Indians and Alaskan Natives are most likely to smoke at over 30% of their population smoking, followed by whites and blacks, whose percentages are about equal, and then Hispanics and Asians, who are much less likely to smoke. Other factors that affect smoking prevalence are education and income. As you can see from this slide, as the level of education increases, the prevalence of smoking decreases, going from 45% of people whose highest level of education is a GED to only 10% of people with a college education and 6% of people with a graduate education. When we consider income, people living below the poverty level are much more likely to smoke than those earning at or above the poverty level. And this is a really unfortunate statistic because these are the people who can least afford the cost of buying cigarettes. The 2012 poverty level for a household of 4 is $23,050 per year. If cigarettes cost $5 per pack and you smoked 1 pack a day, cigarettes would cost $1,838.20 a year, or almost 8% of the annual income in that household. So this is something to keep in mind when you encounter people who smoke, and we'll talk more about the costs associated with smoking and the costs associated with quitting later in the program. Now that we know who is smoking, what is all of that smoke doing to us? You'll see this statement made a lot in publications that come out of the government, out of offices like the CDC and the Office of the Surgeon General, and that statement is, tobacco use is the leading preventable cause of death in the United States. So let's take a look at why that is so. Let's take just one slide to remind ourselves why cigarette smoke is so harmful. Cigarette smoke contains approximately 7,000 chemicals. At least 250 of those chemicals are known to be hazardous to health, and approximately 70 of them are known carcinogens. Some of the worst and most toxic offenders include hydrogen cyanide, carbon monoxide, ammonia, and arsenic. Cigarette smoke, of course, affects the lungs, but it affects almost every organ system in the body, as we'll see in the next few slides. Here are just a few numbers about smoking-related deaths to keep in mind. There are an estimated 443,000 deaths per year due to smoking, and that accounts for about 1 in 5 deaths in the United States. Almost 50,000 deaths a year can be attributed to secondhand smoke, And those who do smoke die on average 13 to 14 years earlier than those who don't. Of all of these statistics, that last one might be the most powerful one to remember and to share with people who are thinking about quitting smoking. That smokers live 13 to 14 years less than non-smokers, because most people will tell you they want to live a long and happy life. They want to see their kids grow up. They want to see their grandkids grow up. And 13 to 14 years is a significant period of time to lose in that lifetime. Of course, the most dramatic effects from smoking are seen in the incidence of lung cancer. First of all, let me say yes, smoking causes lung cancer. If you have read Siddhartha Mukherjee's book, The Emperor of All Maladies, you know that we have not always been able to make that statement, smoking causes lung cancer. So I just want to give a little bit of historical perspective to that issue. In the 1870s, the per capita use of cigarettes in the United States was less than 1 cigarette per year. By the turn of the century, cigarette use in the U.S. had dramatically increased, and then by 1953, the annual cigarette use in the United States was 3,500 cigarettes per person per year. On average, Americans smoked 10 cigarettes per day, and an estimated 4 out of 5 men smoked. Because so many people smoked and only some of them developed lung cancer, it was nearly impossible to prove a connection between smoking and lung cancer. Mukherjee quotes the Oxford epidemiologist Richard Peto as saying this: "By the early 1940s, asking about a connection between tobacco and cancer was like asking about an association between sitting and cancer." And one prominent surgeon in the 1920s, when asked if smoking was causing an increase in lung cancer, reportedly replied, "So has the use of nylon stockings." So everybody was wearing nylon stockings and everybody was smoking, and it was hard to determine what was connected to what. But today, we do know that being a smoker increases the risk of developing lung cancer by an estimated 23 times in men and by 13 times in women. Smoking is responsible for an estimated 90% of all lung cancer deaths in men and 80% in women. And these figures that I have quoted from the American Lung Association and the CDC show the typical increase in risk for men versus women. But there's a new study published in January of 2012 that looked at 50 years of smoking data and found that the incidence of smoking-related disease for men has plateaued and that the incidence in women has continued to rise, so that the two groups are nearly equal in risk now. This is thought to be because men started smoking earlier in history than women, but once women began smoking at rates more similar to those of men, the long-term risk in both groups became more similar. So I think in the future we'll see not so much of a gap between the risk in smoking for men and the risk in smoking for women. Smoking also causes other lung diseases, such as emphysema, bronchitis, and COPD. It's estimated that smoking increases the risk of dying from COPD by 12 to 13 times over that of non-smokers, and that 90% of all deaths from COPD are the result of smoking. Of course, having a chronic lung disease makes patients more susceptible to developing pneumonia, and I've even included influenza here because there's some research that shows an increase in the rate of influenza infection among smokers versus non-smokers, and it's also been reported that smokers have a higher mortality rate from the flu than do non-smokers. Because cigarette smoke affects almost every organ in the body, there are many diseases besides lung disease that are associated with smoking. Smoking increases the risk of coronary heart disease and stroke by 2 to 4 times, and as we know, coronary heart disease is the leading cause of death in the United States, so smoking is contributing to that number. Other conditions strongly associated with smoking are peripheral vascular disease, abdominal aortic aneurysm, cataracts, periodontitis, slow wound healing, infertility, and peptic ulcer disease, just to name a few. And there's also a long list of non-lung cancers that are associated with smoking, and some of them are certain types of leukemias, bladder, cervical, and kidney cancer, cancers of the esophagus, the larynx, the pharynx, and the oral cavity, as well as pancreatic cancer. Certain populations are particularly susceptible to the effects of smoking, and one of those populations is pregnant women and their babies. Smoking is thought to be responsible for 20 to 30% of low birth weight babies, up to 14% of preterm deliveries, and 10% of all infant deaths. The healthcare costs attributed to maternal smoking are estimated at $366 million per year, or about $700 for every smoking mother. The good news here is that smoking rates among pregnant women are decreasing. In 2005, about 11% of pregnant mothers smoked, which is less than the general population, even among women, and is down almost 45% from 1990. Another susceptible group is postmenopausal women. Postmenopausal women who smoke have lower bone density than those who don't, and they therefore have an increased risk of hip fracture as compared to women who have never smoked. And finally, all of us are susceptible to the health effects of secondhand smoke. Secondhand smoke can increase lung cancer in non-smokers by 20 to 30%. And it's estimated that secondhand smoke accounts for 3,400 deaths per year just from lung cancer. Secondhand smoke also increases the risk of heart disease by 25 to 30%. Secondhand smoke is thought to be responsible for anywhere from 20,000 to 70,000 deaths per year from heart disease. Recent studies have even reported that secondhand smoke can increase the risk of an acute MI or unstable angina by 26%. Secondhand smoke is especially harmful to infants and young children. It can be responsible for 150,000 to 300,000 lower respiratory tract infections a year, and from those infections, 7,500 to 15,000 hospitalizations result each year. And secondhand smoke is also thought to be associated with approximately 400 SIDS deaths per year. Secondhand smoke also increases the incidence of middle ear infections in infants and young children and can exacerbate the symptoms of asthma in children who are around secondhand smoke. So we know who is smoking and we know what it's doing to us, so how much is it costing? According to the American Lung Association, in 2010, the tobacco industry spent over $8 billion in advertising, but the U.S. healthcare system spent nearly $96 billion taking care of people with smoking-related illnesses. The American Lung Association also estimates that every pack of cigarettes smoked costs the U.S. economy $18 per pack. I think most smokers are aware of many of the dangers of smoking. They hear that all the time. But they may not be aware of the benefits of quitting. And what's more, the benefits of not smoking begin as soon as a smoker quits. Within 20 minutes after quitting, the heart rate drops back to normal levels. At 12 hours after quitting, the carbon monoxide level in the blood begins to return to normal. At 2 weeks to 3 months after quitting, the risk of having a heart attack begins to drop and lung function begins to improve. And then at 1 to 9 months after quitting, coughing and shortness of breath decrease. In addition to the immediate benefits, the benefits of quitting smoking continue to accrue years after a smoker quits. And the same 2013 study that showed the health risk of smoking for women are nearly equal to those of men also showed that when smokers quit by the age of 40, the health risk can be completely reversed over time. So 1 year after quitting, the risk of coronary heart disease drops to half that of a smoker's risk. At 5 to 15 years after quitting, the risk of having a stroke is reduced to that of a non-smoker's risk, and the risk of getting cancer of the mouth, throat, or esophagus is half that of a smoker's. At 10 years after quitting, the risk of dying from lung cancer is about half that of a smoker's. The risk of getting bladder cancer is half that of a smoker's, and the risk of getting cervical cancer or cancer of the larynx, kidney, or pancreas all decrease. And at 15 years after quitting, the risk of coronary heart disease is the same as that of a non-smoker. So if a patient stops smoking by age 40, many of the increased risk from smoking can be reversed by age 55. So that's important information to keep in mind when you're talking with people who want to quit or who are thinking about quitting. So how can we help smokers stop smoking when they decide they're ready to quit? According to the CDC, almost 70% of current smokers say that they want to quit smoking, and in 2010, over 50% of smokers tried to quit. People know the risk of smoking, they know they're addicted, and they want to quit. But because of the highly addictive nature of nicotine, it is really hard to stop smoking. I just want to mention here, before we start talking about cessation products, that the best way to stop smoking is to prevent teens and young adults from ever starting in the first place. If you'll remember the prevalence slide from earlier, about 20% of the U.S. population smokes, and about 19% of teenagers smoke. This means that most people who smoke start smoking when they're teenagers. In fact, the Surgeon General reports that almost no one begins smoking after the age of 25. So government and private efforts should be aimed at media campaigns to stop smoking, higher cigarette prices, smoke-free laws, which we're seeing more and more of today, and school or community programs aimed at discouraging teenagers from smoking. Because if we can keep them from ever smoking to begin with, then they don't have the problem of how hard it is to quit when they decide they don't want to smoke anymore. But if we can't get to people before they start to smoke, then we need to provide them with realistic information when they decide to stop. One thing that we need to remind people is that quitting smoking is hard. Many smokers make several attempts to quit before they're successful. Some estimates are as high as 6 to 8 times before they actually finally stop smoking. But again, there's good news. Since 2002, the number of former smokers in the United States has exceeded the number of current smokers. So people are being successful in their attempts to quit. So we need to continue to encourage smokers to keep trying to quit even if they've tried before, because one time it's going to work and they're going to be successful. Some of the most commonly used smoking cessation products are the nicotine replacement products. The first nicotine gum, which was Nicorette, was approved in 1984 and is still available today, along with the brand name Thrive and various other generics. These products are available over the counter now, and so they're really easy for patients to get. Nicotine gums come in a variety of flavors, I'm sure you've noticed. There's original mint, there's ice mint, there's spearmint, there's cinnamon, and there's fruit flavors. So we can accommodate a lot of tastes and preferences with this product. The gum also comes in 2 milligram and 4 milligram strengths, so patients need to know which one is right for them. If a patient smokes their first cigarette within 30 minutes of waking up in the morning, they should use the 4 milligram gum, and everybody else should use the 2 milligram gum. For the best chance of success, it's recommended that patients use at least 9 pieces of gum per day for the first 6 weeks, and they should use the product for at least 12 weeks to ensure best success of quitting. Using the recommended 12-week schedule, patients should chew 1 piece of gum every 1 to 2 hours for the first 6 weeks, remembering that they need to use at least 9 pieces a day for the best chance of success. Then in weeks 7 to 9, the dose is decreased to 1 piece every 2 to 4 hours. And finally, in weeks 10 to 12, patients should drop back to 1 piece every 4 to 8 hours as needed. Of course, chewing nicotine gum is not like chewing bubble gum. There are specific directions on how to chew. And those directions are to chew the gum until there's a tingling sensation in the mouth. Some people describe it as a tingling, some people describe it as a peppery taste, but you chew until that happens, and then you stop chewing until the sensation or the taste goes away. When the tingling goes away, then you chew the gum again until it returns, and then stop chewing. And this process is repeated over 30 minutes, and then the gum is thrown out. The gum may still contain nicotine, so it's recommended not to swallow the gum, but instead throw it away. Another product very similar to the gum is the nicotine lozenge. It's also available over the counter, and the lozenges are available as brand name Nicorette and various generics. There used to be a Commit brand, but I think that brand has now become Nicorette. So if you know something different than that, type that into the chat box and let me know. But I think there's no longer the Commit brand. Nicotine lozenges come in mint and cherry flavors, and they're also available in 2 milligram and 4 milligram strengths. The criteria for choosing the 4 milligram or the 2 milligram and the dosing recommendations for the lozenges are the same as for the gum. And there's also now a mini lozenge, which dissolves up to 3 times faster than the original nicotine lozenge. The recommended 12-week schedule is also the same for the gum and the lozenges, and you can see from the table on the slide that again there are specific directions on how to use the lozenge. So patients should not eat or drink for 15 minutes before using a lozenge or while the lozenge is in their mouth. They should allow it to dissolve slowly while moving it back and forth from one side of the mouth to the other over a 20 to 30 minute time period. And of course, the lozenge should not be crushed or chewed or swallowed because that would deliver too much nicotine at once. So you want to let it dissolve slowly in the mouth. Precautions for using the gum and the lozenge are also very similar. Since these products contain nicotine, patients must stop smoking while they're using these products or they risk having side effects from nicotine overdose. These products can also be dangerous to children and pets, so they should be stored in safe places where small children and pets can't reach them. And the gum should be wrapped in a tissue before being thrown in the trash to prevent it from being chewed by a child or a pet who might go digging through the garbage. And finally, there are recommendations to prevent overuse of these products, which could also lead to side effects. Patients should use no more than 5 lozenges in 6 hours, or 20 lozenges per day. They should not use more than 24 pieces of gum per day. And the overuse of these products can cause hiccups, heartburn, and nausea, or any of the other side effects of nicotine overdose. Another very popular nicotine replacement product is the nicotine patch. These were first available in the early 1990s as prescription products. They are, of course, now over the counter, and they're marketed as Nicoderm CQ, Habitrol, and many generics. You're probably familiar with the Nicoderm CQ ad campaign right now, the I Just Want to Celebrate campaign that encourages smokers to really celebrate and have a party every time they resist that urge to smoke. So these are still heavily marketed products even after 20 years. And I think they're a particularly popular choice among patients because it seems like it's easier to wear 1 patch a day than to chew 24 pieces of gum or suck on 20 lozenges. The nicotine patches use a tapered or stepped-down dosing system that lasts anywhere from 8 to 10 weeks. That also used to be an ad campaign where the smoker was stepping down, like coming down steps as they were stepping down to these different dosage levels of the patch. So for Nicoderm, patients who smoke more than 10 cigarettes per day start at step 1, which is the 21 milligram patch, and use it daily for 6 weeks. Then they step down to the 14 milligram patch for 2 weeks, followed by the 7 milligram patch for 2 weeks. Patients who smoke 10 cigarettes or less per day start at step 2, which is the 14 milligram patch, and use it for 6 weeks. Then they step down to the 7 milligram patch and use that for 2 more weeks. The Habitrol dosing scheme follows an 8-week plan instead of a 10-week plan like the Nicoderm CQ. Patients who smoke more than 10 cigarettes per day again start at step 1, the 21 milligram patch, and use it daily for 4 weeks instead of the 6 weeks on the Nicoderm. The rest of the step-down plan is then the same. Patients move down to the 14 milligram patch for 2 weeks, followed by the 7 milligram patch for 2 weeks. Patients who smoke less than 10 cigarettes per day, the dosing scheme is the same as with Nicoderm. They start at step 2 and use the 14 milligram patch for 6 weeks, and then they step down to the 7 milligram patch for 2 additional weeks. The directions for applying a nicotine patch are pretty similar to other patch products that you're familiar with. You want to apply the patch to a clean, dry area of skin that's hairless, avoiding any areas of skin that might have cuts or scratches or any other type of irritation. You apply the patch and apply pressure to the patch for about 10 seconds to ensure that you have good adhesion, and you want to use a different site every day. Most people use the upper arm with these nicotine patches, but they can really be placed on any hairless area of the body. If you have cigarette cravings in the morning, you should wear the patch for 24 hours and change it at the same time each day. If wearing the patch overnight interferes with your sleep, if it causes you to have vivid dreams or restless sleep, you should remove the patch at bedtime and then reapply it at the same time every morning. The precautions for use of nicotine patches are pretty similar to those for the gum and the lozenges. First of all, patients must stop smoking while they're using the patch, even when the patch is removed, because there's still nicotine present in the bloodstream, of course, even if you've taken the patch off. So in order to avoid those side effects from nicotine overdose, they have to stop smoking. Again, because a removed patch still has nicotine in it, it's important to keep the patches away from children and pets, just like with the gum and the lozenges, really. So you need to store them away from small children and pets, and it's recommended that you keep the foil pouch that the patch comes in, so that when you remove a patch, you fold it together with the sticky ends together, place it back in that pouch, and throw it away in that, and that will, hopefully help keep small children and pets who might be in the trash can from finding it and being able to get to it. And then again, because this is a topical product, the patch can cause some mild skin irritation, but it should not be anything severe. When you look at the prices of these OTC nicotine replacement products in the store, they seem pretty expensive. So patients might be tempted to say they can't afford to stop smoking because the products are too expensive. But when you compare them to the cost of smoking, they aren't that expensive after all. The table on this slide represents just some quick calculations that I did to get an idea of what using these OTC products cost versus the cost of smoking. So here's what I did. I used the American Lung Association's estimate of $5 per pack for cigarettes and assumed that the patient smoked 1 pack a day. So the estimated cost of cigarettes column refers to an equal time period as the replacement product would be used. So for the gum and lozenges, that value represents 12 weeks of buying 1 pack of cigarettes per day at $5 per pack. For the patches, I used 10 weeks as a typical course of therapy, so that's why that value in that column is a little bit less. It's 12 weeks for the gum and lozenges versus 10 weeks for the patch. Then I went to a big box store in Greenville, South Carolina to get prices on brand and generic nicotine gum, lozenges, and patches. For the gum and lozenges, I used an estimate of how many pieces a typical patient might use in one day. So I used an estimate of 12 pieces per day for the first 6 weeks, then 8 pieces per day for weeks 7 through 9, and 4 pieces per day for weeks 10 through 12, and then I added up the total cost of that therapy. As you can see from the table, when we compare gum and lozenges, it might be a little more expensive to use lozenges, but both of those smoking cessation aids are less expensive than buying 1 pack of cigarettes per day for the same time period. The patches are the most expensive OTC choice, but again, the cost in my estimate is equal to or less than that of buying cigarettes for the same time period. So in your handout, I've included a math worksheet of these estimates and calculations that I used. If you want to try these calculations based on the prices of cigarettes where you live, because I know that varies a lot across the country, and on the cost of the OTC nicotine replacement products in your store. So you could have this cost comparison to show a patient if they thought it was too expensive to buy those products to try to stop smoking. There are still 2 nicotine replacement products that are only available by prescription, and they are the Nicotine Inhaler and the Nicotine Spray. The inhaler is marketed as Nicotrol, and there are no generic equivalents for this product. This product consists of a nicotine cartridge that's placed inside the inhaler, and then the inhaler device is puffed like a cigarette. This way, the patient is receiving nicotine to reduce cravings and is also satisfying the hand-to-mouth habit created by smoking cigarettes. Although there is no evidence that that hand-to-mouth action improves quitting success over the nicotine alone, but that's the theory behind that product. As you can see from the picture in this slide, the inhaler does look sort of like a cigarette. It's supposed to be used in puffs or short breaths over a period of about 20 minutes, just like you would a cigarette. Just like with the gum and lozenge products, patients need to use the inhaler more often and for longer periods of time when they first start therapy, but they should not use more than 16 cartridges per day. I don't have the impression that this product is used very often. I think I may have seen one of these inhalers in the past year. So type in the chat box and let me know what your experience is, if that's your experience or you have a different experience. But again, it's just my impression that it's not prescribed very often. I just wanted to briefly mention the other prescription nicotine replacement product, and that's the nicotine nasal spray, which is marketed as Nicotrol NS. And again, I don't think this is widely used. It's still listed as active on the Drugs at FDA website, but I don't remember the last time I saw one of these. So type in the chat box and let me know if that's your experience or if you think differently. For this product, one dose is considered one spray in each nostril or 1 milligram of nicotine. So basically one spray in each nostril equals 1 milligram of nicotine. And you'll notice from the slide that patients can use up to 40 milligrams per day. Well, if each bottle of nicotine nasal spray contains 10 mLs, that's 100 milligrams of nicotine, so that would be almost half a bottle a day. Not only is that a lot of sprays in the nose, but I think that would also get pretty expensive. And unlike the other nicotine replacement products, there's no prescribed tapering schedule for this nasal spray. Patients are just told to taper off of the spray at their own rate. The side effects of these nicotine replacement products are generally all the same, so I've just made one slide to cover them all. Nicotine itself can cause irregular heartbeat or palpitations, so you can of course see those from these products. And the use of these products, and especially the overuse of these products, can also cause things like nausea, vomiting, diarrhea. They can cause weakness, dizziness, and again, rapid heartbeat, especially from overuse. So if patients experience these side effects, they should decrease the amount of product that they're using. Specifically for the gum and the lozenges, since they are used in the mouth, they can cause pain or irritation inside the mouth, and they can also cause teeth or jaw pain. And again, patients should be cautioned not to use the gum or lozenges one right after the other because using them that way can actually cause hiccups, heartburn, and nausea. And for the patches, I think I already mentioned, of course, they can cause local irritation at the patch site. So some redness or irritation is normal, but a redness or a swelling that lasts for more than 4 days is not normal. This may be a sign that this particular patient is not a good candidate for the patch and that they should switch to some other smoking cessation product. In addition to questions about side effects, this question always comes up, doesn't it? Can I use these when I'm pregnant? Well, nicotine is known in animals and humans to cause harm to a developing fetus. But smoking is also known to cause harm to the developing fetus, and cigarette smoke contains far more damaging chemicals than a nicotine gum or patch or a lozenge. So pregnant women are encouraged to stop smoking without the use of a nicotine replacement product. But if that is not possible, the use of these products is considered safer than smoking. And in general, products like the gum and the lozenges are preferred over the patches because the dose of those is intermittent and not a continuous dose of nicotine like it is with the patch. In addition to nicotine replacement products, there are a couple of unique prescription products that are approved as smoking cessation aids. Varenicline was approved in 2006 and is marketed as Chantix. Varenicline is thought to bind to the nicotine receptors in the brain, like a nicotine replacement product, but in addition, it also decreases the release of dopamine that results after binding to the nicotine receptor. And this decrease in dopamine release helps to further decrease the cigarette cravings that drive smoking behavior. Because there is no nicotine in this product, patients can continue to smoke for the first couple of weeks of therapy, and that is a really attractive option to a lot of smokers. I am not a smoker, never been a smoker, but I have worked with smokers who have tried many times to quit, and one of them told me that this was the first product that really worked, and that it was the first thing that made her not feel like smoking when she used it. So I'm sure many of you have heard similar stories from your friends or your relatives or the patients in your store. A lot of people really feel like this product is different. Since the product most similar to Varenicline is Bupropion, clinical trials compared these two drugs, and Varenicline was shown to help 44% of patients quit while on therapy, as opposed to 30% of the patients on Bupropion and 18% of patients taking a placebo. So it has been shown to be an effective option compared to what's available. Because nausea is such a side effect of this drug, the dose of Varenicline is tapered up at the start of therapy to reduce that. So for days 1 through 3, patients take 1/2 milligram by mouth daily. At day 4, this is increased to 1/2 milligram twice a day. And then starting at day 8 and continuing until the end of therapy, the dose is increased to 1 milligram twice daily. It's recommended that Varenicline always be taken with food or water to reduce those gastrointestinal side effects. And if patients are successful in quitting after 12 weeks, then it's recommended that another 12 weeks of the 1 milligram BID therapy be continued to increase that patient's chance of success. Patients who do not quit smoking at the end of 12 weeks are encouraged to try another course of therapy at a later time after any reasons in their life that contributed to them not quitting have been addressed. Social issues, economic issues maybe, things like stress or family and friend influences. I know stress you can maybe do something about because that will kind of come and go in your life. And so maybe you could try at another time when there's not so many stressful things going on. Family and friend influences are tough. I guess in theory you could get rid of your friends and try to find some more friends, but it's really tough to get rid of your family. My coworker, who told me that Varenicline was the first thing that ever worked for her and made her not want to smoke, she quit smoking for several months, and then she started back because her husband smoked. And so there she was in the house with him all the time with him smoking, and she started back smoking. So family and friend influences are really tough ones to deal with. And then finally, that dose can be reduced if it's needed because of side effects or because of renal insufficiency. And the cutoff there on the renal insufficiency is that 30 mLs per minute creatinine clearance. So there's no particular dosing recommendation. It just says to reduce the dose. So you would probably go back to 1/2 milligram twice daily would, maybe be the first most logical step. You've probably all seen these Chantix boxes, but I just want to remind you, because of that tapering in the first month, Chantix comes in 2 different ways. There's a starting month box and then the continuing month box. So the starting month box contains 1 blister card of the 11 1/2 milligram tablets that you would need at the beginning of the taper, and then 3 blister cards containing 14 1 milligram tablets each for the remaining 3 weeks of that first month's therapy. And then after that, patients get the continuing month box, and each of those boxes contain 4 blister cards of 14 1 milligram tablets, 1 for each of the 4 weeks of the month. And so as you can see from the slide, which is a nice one that I borrowed from Pfizer, the 1/2 milligram tablets are white and the 1 milligram tablets are blue. Varenicline is not marketed as an antidepressant, but because of its mechanism of action and its effect on dopamine levels in the brain, it carries similar warnings to some antidepressant therapies. So there is the boxed warning related to serious neuropsychiatric symptoms, and that list of symptoms is depression, mania, psychosis, hallucinations, paranoia, delusion, homicidal or suicidal ideation, hostility, and agitation. So these symptoms should be reported to a doctor as soon as they are noticed, and the therapy should be discontinued immediately. Some of these symptoms are known to be symptoms of nicotine withdrawal, but some of them are not. They can occur in patients with and without pre-existing psychiatric illnesses. They usually occur while patients are taking Varenicline, although they have occurred in patients who had stopped the therapy. The symptoms usually resolve after the Varenicline is stopped, but some patients have had symptoms that continue even after discontinuation of therapy. So there's no clear answers here, but all patients should be monitored for these symptoms, and the benefits and risk of using this drug should be weighed for each patient. So assuming that patients don't have a psychiatric reaction to varenicline, the most common side effects reported are gastrointestinal side effects. Nausea that we've talked about also includes constipation, gas, and vomiting. And patients have also reported vivid or unusual dreams while taking this therapy. Varenicline is pregnancy category C, so the only guidance that we're given is it should only be used in patients if the benefits outweigh the risk of the therapy. This is another slide with a graphic produced by Pfizer, the makers of Chantix, comparing the dosage schemes and the out-of-pocket costs for various smoking cessation aids. The graphic makes a good point about the gum and the lozenges, and that is if you are using them, you're going to be using a lot of them, especially at the beginning of therapy, so some patients might find that less convenient than other therapies. As for costs, some insurance plan will pay for varenicline, so that would represent the patients with the lowest cost, and some insurance plans don't, or some people don't have insurance, and so the $6.39 per day figure that they have on this slide would represent an average cash price to the customer. So 12 weeks of therapy at $6.39 per day would be just over $500 for a 12-week course of therapy. Double that if you quit and decide to do a second 12-week course. But it's still not really far out of the range of what a patient would be spending on cigarettes during the same time period. If you do have patients coming to your pharmacy with Chantix prescriptions, be sure that they check the Chantix website for coupons before filling that prescription. That's www.chantix.com. This coupon that I found will reduce your copay down to $40 if your out-of-pocket costs are $115 or less. And if your out-of-pocket costs are over $115, then the coupon will reduce your cost by $75, and you can use this coupon up to 3 times. So that would get you through one 12-week course of therapy. So especially with the expensive brand name stuff, always have people check the website for coupons because a lot of times you can find some pretty decent ones. The other non-nicotine smoking cessation aid that's available by prescription is Bupropion or Zyban. Bupropion is, of course, an antidepressant marketed as Wellbutrin, and it was found that patients taking Wellbutrin seemed to have less of a desire to smoke. So clinical trials were done, and Bupropion was approved and marketed as Zyban for smoking cessation in 1997. Zyban 150 milligram tablets are still available, as well as many generic options. Bupropion is a weak inhibitor of norepinephrine and dopamine uptake, but its exact mechanism in smoking cessation is not known. It contains the same type of box warning about psychiatric symptoms as Varenicline, and the most common adverse effects are dry mouth and insomnia. Bupropion is also pregnancy category C, so the risk and benefits of using it in a pregnant patient should always be considered. Because of a risk of seizures with Bupropion, the starting dose is tapered similar to Varenicline. Patients start at 150 milligrams once daily for 3 days, and then increase to 150 milligrams twice daily for the remainder of therapy. Again, patients can continue to smoke while taking Bupropion because there's no nicotine in this product. They should start the drug and then set a quit date within the first couple of weeks. If a patient succeeds on therapy after 7 to 12 weeks, continuation of therapy should be considered to improve the chances of success. If a patient does not quit after 7 weeks, it's unlikely that they will quit in this attempt, so the therapy should be discontinued and tried again later. Bupropion is certainly available, but it's no longer aggressively marketed. Varenicline seems to be the more effective option, and I think patients who go to their physicians looking for smoking cessation help are more likely to receive a prescription for Chantix than for Zyban. However, for patients who can't take Varenicline or need some other therapy alternative, you may see a Bupropion prescription used. We'll wrap up this program and summarize what we've talked about by looking at the pharmacist's role in helping patients who want to stop smoking. First, remind patients that quitting is difficult and it may take them more than one attempt. Remember, some estimates say 6 to 8 attempts before they are successful. So even if they've tried before, they should still keep trying until they are successful. It only takes one successful attempt to be a non-smoker. So encourage them to keep trying. Explain to them the benefits of quitting. Everybody knows how harmful smoking is, but I think the list of benefits is less well known. And also, if they're younger patients, let them know that quitting by age 40 nearly reverses the harmful effects of smoking in just a few years. Educate them on the products that are available to help them quit. You have lots of products in your store, but if they don't want to use a nicotine replacement product, then you can tell them what's available if they visit their doctor. Counsel them on the correct use of whatever product they decide to use. Remind them that too much nicotine causes side effects, and overuse of gum and lozenges can cause hiccups, heartburn, or nausea. And remind them to watch out for the psychological symptoms that can sometimes occur with Varenicline or Bupropion, and to stop their therapy immediately and notify their doctor if that happens. Encourage patients to get support. Smoking cessation products help, but having support helps too, and it increases their chances of a successful quit. And finally, know where to find those quitting resources, which I have listed for you on the next slide. First of all, if patients choose a brand name smoking cessation product, that product will have free support services provided by the manufacturer. So encourage patients to take advantage of that free support, and it can be in the form of online support or live support via telephone. In addition to support provided by product manufacturers, many organizations offer free smoking cessation support. No one should ever pay for a smoking cessation program. There are too many good options that are absolutely free. The American Lung Association has a Freedom from Smoking support program. There are several government-supported programs that can be found on the CDC website. There's smokefree.gov, along with more specific programs such as Smoke Free Women and Smoke Free Teen, and they have a 1-800-QUIT-NOW phone line for support. The American Cancer Society offers the Quit for Life program and sponsors the Great American Smokeout every November, where their motto is "Everyone Loves Quitters." And they also have an 800 number for live support. The American Heart Association does not have a smoking cessation program, but they do have lots of good information on their website about smoking, and in particular the cardiovascular risk associated, and their site includes a cost of smoking calculator that's nice to tell people about. And finally, there's always an app for that. So here are some good apps that you can recommend to people. Livestrong has My Quit Coach, and this app lets patients create a personal plan for quitting, gives them motivational tips, and tracks their progress with charts, and you can even earn badges as rewards for your progress. Another one is My Last Cigarette, and this app focuses on the health benefits as patients quit smoking, so we've been talking about emphasizing the benefits, and it shows them what benefits their body are receiving as their smoke-free time increases. There's one called Quit Now, and this app lets patients join chat rooms and talk with other people who are trying to quit smoking, and it tracks the amount of money that you've saved by not smoking. There's Kick Smoking. This one has a timer that tracks the amount of time patients have been smoke-free, and it also lets them track the number of temptations resisted and calculates the number of cigarettes that they haven't smoked. So kind of shows you, the additive effect of your efforts. And the last one I have listed here is called Quitter, and this one also tracks the time since the patient's last cigarette and the amount of money saved, but it lets you post your progress to Facebook and to your other social media sites so you can brag about your progress and hopefully get encouragement and support from all of your social media friends.